Hey guys, so for my journal club presentation, I'm going to do a PICA question of in the adult population, does the long-term effects of COVID, otherwise known as long COVID, increase the EBV levels and act like a reactivation of EBV? So basically, we had a case of a 49-year-old woman who had a complaint of fatigue, headaches, tinnitus, dizziness, and some double vision since she tested positive for COVID 3 months ago. The patient has had continual symptoms since the start of her contracting COVID, increase in headache and vision changes with noise and with light sensitivity, fatigued easily. She can only get like a load of laundry done and then has to sit down for 30 minutes to an hour. She is an EMT, so she hasn't been working since she got COVID 3 months ago. And she has 4 children at home, which she said is very difficult to take care of while she's still feeling this effect of long COVID. She recently had a chest x-ray, CT scan of the chest, and an MRI of the brain, just to rule out some different things. All were negative. She received endless amounts of blood work, so pretty much every panel you can order, we ordered it on her. All were normal except for a slight elevation in lymphocytes. She tested negative for COVID multiple times since she first contracted COVID, and she tested negative for the flu and also for strep. She did test positive for EBV though on a monospot. So basically the article I picked, I wanted to see if there was a correlation with the EBV reactivation and long COVID. And in this article, there had been a higher frequency of viral infections leading to triggering long COVID. Specifically, EBV had been shown to have the highest frequency in the acute severe COVID-19 infections, and in the study they analyzed whether long COVID fatigue was triggered by the SARS in the GI or respiratory tract, or if it was due to reactivation of EBV. They tested the SARS in the stool and the throat washings, and they also tested the EBV in the stool, throat, and blood by real-time PCR and RT-PCR. Samples were collected between 74 and 471 days after the acute COVID infection in 30 long COVID patients, and these patients presented with fatigue, post-exertional malaise, orthostatic dysfunction, and autonomic dysfunction. 20 age sex-matched patients who had previously recovered from COVID were used as controls. Their samples were collected between 106 and 571 days, and each group found a median in the mid to upper 200 range for the day of specimens that they were collected on. They also analyzed specific antibodies, including the SARS IgG and IgA with ELISA assays, and the SARS RNA was not detected in the throat or stool washings in any of the RT-PCRs. The EBV PCR was negative in all blood and stool samples, but was detected in the throat washings in 15 out of 30 of the long COVID patients and 14 out of 20 of the control group. The EBV levels between the control and the long COVID patients were not significantly different. So this is just a graph that or a picture that they had put in their study, basically, showing that the long COVID patients, there was about those 15 above that showed the EBV, and the control group was about only 4. So they basically, all patients in the study but one had previously tested positive for EBV, which was seen with the IgG seropositive and the IgM seronegative status, which means that the replication that was observed during this research was actually a reactivation of EBV, not a primary infection. The p-value of the study also was less than 0.05, which is considered significant. The outcome of the study basically just represented that those with long COVID can have an EBV reactivation that plays a role in the development of their long COVID symptoms. So in this article, for their strengths, the research was seen to be strong with a small p-value that was significant. They thoroughly explained how their research was run and had control groups to compare to for better confirmation of a difference in those with long COVID and the reactivation of EBV. And then for their limitations, the article had a really small sample size, which limits the effectiveness of any study. They also didn't include an HLA subtype, and they actually put that in like a disclosure at the bottom that this is a big limitation for them. And basically, earlier reports of differences in the EBV antibody profile could not be confirmed, which was also due to the small sample size. And then further and larger studies are needed to clarify whether EBV and its impact on long COVID fatigue is that significant. So basically, reflection and practice. I think in practice this can be used to see whether a patient who has long COVID has a reactivation of EBV to better treat their symptoms. So for instance, an EBV reaction and the knowledge of it in those with long COVID could help us recognize the importance, even more so, of these patients resting, staying hydrated, and being able to fully recover from the EBV viral reactivation as well as long COVID symptoms. And I think there has to be definitely more research on this topic to firmly say it would change a clinical practice or not. But this is fairly new, obviously, and I think it's pretty important to look into. And this is a reference that I used, the article that I used, so just the Epstein-Barr virus reactivation development of long COVID fatigue. And that's it.